Hola, hola. Uno, dos, tres.
No llega. Hola, hola, hola. Uno, dos. Probando sonido. Hola, hola, hola. ¿Y esa hora que tenés ahí?
La puse
Para ver la
demora.
demora.
Image in the upper quadrant
Hola,
there,
hola.
and there's extensive lipid a little bit further
Uno,
down in the
dos,
lesion with evidence of
tres.
thin cap fiber atheroma.
Fíjate
So
si me
as per the
escuchas ahí.
randomization, this lesion will be
Hola,
managed
uno, dos,
medically,
tres.
but as part of the OCT study,
Probando
we'll be able to
sonido.
evaluate what happens prognostically to
Hola.
these lesions when they are left without intervention. Here's another example. This is a 65-year-old patient with a high-risk
Hola,
non-STEMI.
hola.
Unlike complete
Uno,
evidence,
dos.
the two non-STEMIs where the culprit lesion can be clearly and unequivocally identified by the operator can be randomized. So this patient had a clear culprit in the proximal circumflex. The LAD and right coronary artery had disease. In the LAD's case, the lesion was significant enough visually to be randomized. This patient was randomized to physiology guidance as well as included in the OCT study. The LAD lesion was assessed by physiology. The physiology value was positive. The lesion had evidence by OCT of layered plaque, indicating likely recent plaque progression within the last number of months or so. And there was also evidence of intraplaque hemorrhage within this lesion. Again, we're really struck by how many of these lesions have evidence of plaque activity when you deal with this high-risk phenotypic subset. So this patient then, based on the trial, underwent PCI. The treatment decision is not guided by imaging. It's guided by the abnormal physiology result. But the OCT was used to optimize the PCI outcome. And you can see in this case, there was need based on the final or the follow-up OCT for further post-dilatation in the distal portion of the stent, which was done. And then in the circumflex was also imaged, again with the intent to do multi-vessel image interrogation. The right coronary artery was a non-significant vessel. There was no intent to randomize in this vessel, but imaging was also performed as part of the natural history assessment. And here, very interestingly, we see evidence of previous plaque rupture and a healed cavity, as well as both cholesterol crystals and microvessels. So pleased to share that the study has now crossed the halfway point. Over 2,500 patients have been randomized in multiple centers around the world, and the OCT component also has more than half of the target enrollment. From a Latin American perspective, we're happy to say that a number of Latin American countries are very close or soon to be starting up, including Mexico, Costa Rica, Colombia, and Argentina. So that concludes my comments, and I welcome to have any questions.
Thank you, Dr. Seth, for such an amazing lecture. En este momento tenemos tiempo para una o dos preguntas. Si hay alguien en el público que quiera acercarse, ir formulando la pregunta, por favor. En este tiempo me gustaría hacerle yo una pregunta al Dr. Tesh. I have a couple of questions. The first one is, do you think that there should be a standardized protocol to evaluate these non-culprit lesions, always using both techniques, always using maybe a sync vision approach with physiology and imaging? Do you think maybe IBUS is going to take a step back and OCT, because the unstable plaque characteristics is going to take a step above and maybe use it, or maybe physiology is going to disappear and maybe you should only choose one technique and stay with OCT?
Yeah, so two great questions. First, I would say I think for imaging in general, there is a challenge as of yet to identify a clear imaging surrogate or parameter that would guide our treatment. So as an example, we're not yet confident that operators in the lab can reliably identify a thin cap fiber atheroma when they do the OCT and just look at it. And if you're asking them to then use their treatment on that basis, I think could be a challenge. Perhaps the future involves post-processing with AI or such sophisticated techniques that won't just pick up one variable, but maybe look at all of the variables and estimate a lesion level risk. I think that's the goal of the OCT study in part, is to collect those clinical outcomes so we can eventually have, at the point of care, rapid evaluation of imaging parameters to guide treatment. And that's particularly because it's probably not so simple as to say, if there's a TICFA, go ahead and put a stent. We probably have to look at more than that simply one variable. The other question that you asked about whether physiology will go away or be less important, I think this is really what the trial is trying to address. I think, in the community, there are many proponents of physiology-guided intervention, both for stable and acute patients, and there are others who feel that, as I outlined, the equipoise, that angiographically guided might be sufficient. So I think the trial will answer the question. A last comment about the role of OCT in acute coronary syndromes versus physiology. I would say that clearly OCT has a number of advantages, including the ability to assess fibrous cap thickness, the presence or absence of thrombosis, plaque rupture, and so forth. And some of these very subtle findings that we're now starting to identify as we do more ACS imaging, like intraplaque hemorrhage, like layered plaque, these are unique findings in OCT. And it's up to us as imagers to identify what these things mean from a long-term perspective, but I think there's a richness available in the OCT data set that makes it very attractive for use in ACS.
Thank you. ¿Alguien con una pregunta más? Is there a specific role for other imaging techniques like NIRS in the future?
I'm not sure that NIRS, I believe NIRS is not actually being actively commercialized any longer. I really think that the future probably is a combination of intravascular OCT and IVUS in some degree. Both have a big role in clinical practice. As I said, we're particularly interested in the role of OCT and ACS.
Vamos a dar por terminada esta sesión, agradecer al doctor Tesh por una excelente conferencia magistral. Por favor, quédense aquí en el auditorio porque tenemos en unos minutos más el inicio de la transmisión del caso en vivo desde el Instituto Nacional de Cardiología. Un aplauso para el doctor Tesh, por favor.
Sí, voy a coordinar. Buenos días. Si gustan tomar asiento, por favor, y los panelistas pasar al presidio. ¿Nos conocemos también? Nacional de Cardiología. Es un caso en vivo coronario. Yo soy la doctora Patricia Martín, soy